Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello and welcome to Medscape Global Oncology CME CE event today, titled New Frontiers in Non-Small Cell Lung Cancer, the Promise and Progress of HER2-Directed Therapies. I want to introduce myself and the esteemed faculty joining me today. I'm Martin Dietrich. I'm a medical oncologist and assistant professor of medicine at the University of Central Florida in Orlando. I'm being joined by my colleague, Dr. Antonio Passaro, medical oncologist in the Division of Thoracic Oncology at the IRCCS European Institute of Oncology in Milan, Italy. Dr. Shani Shilo, founder and CEO of the Israeli Lung Cancer Foundation, committee chair of the ISLAC Patient Advocates Committee, and then Dr. Siram Yang, attending pathologist in thoracic pathology and diagnostic molecular pathology, co-director of biomarker development, early drug development service in solid tumor oncology at Memorial Sloan Kettering Cancer Center in New York. I want to take a look at briefly here for the non-small cell lung cancer mutational landscape. As you can see, both in early and metastatic stage, and I think this has been really finding our way into the therapeutic armamentarium in both early and late stage diagnostic, that we're seeing really a diverse presentation of genetic alterations in non-small cell lung cancer. And you can see here that there is a separate section for ERBB2 or HER2. The nomenclature is interchangeable in the non-small cell lung cancer context. And most of us in the clinical context prefer HER2. I think genetically more accurate is ERBB2 in the family of ERB oncogenes. That this is a subset of lung cancer that may not be a high percentage of non-small cell lung cancer, but given the large presentation of non-small cell lung cancer patients here, we're actually looking at a significant number of patients that we are not serving properly by not identifying their respective biomarker. You can see KRAS, EGFR, dominating here across the early and late stage disease space, and many other mutations as well. So very important to be specific for treatment. HER2 is a very diverse biomarker. We see alterations in different varieties. The most important one, and this will be the topic of our discussion today, are the HER2 mutations. Those are intracellular kinase domain mutations, typically in exon 20. You can see it's very different from the chemical cousin in EGFR or ERBB1, where EGFR exon 20 is a rare alteration. For HER2, exon 20 dominates, and you can see the A775, G776 insertion mutations really here by far the most common mutations. We see ERBB2 amplifications. Those are oftentimes resistance events that we're seeing post-treatment with EGFR, but we can also see them de novo. And then HER2 overexpression, a marker that actually has been approved in the United States and included in the guidelines. You can see the characteristics of ERBB2 really resemble what we would see, especially in the mutation setting, resemble what we would see in an EGFR patient population. Is a predominantly female population. We see more younger patients. We see more patients that have never smoked or have a light smoking history in a predominantly adenocarcinoma background. And then obviously a yet to be defined role of immunotherapy in this type of non-small cell lung cancer. Here you can see the NCCN guidelines, first-line treatment based on standard chemotherapy plus or minus immune checkpoint inhibitor, and then preferred treatment here upon progression with trastuzumab deruxtecan or adotrastuzumab emtansine as another recommended regimen with further treatment, probably based on standard of care chemotherapy or clinical trials, depending on performance status. With that said, ERBB2 or HER2 really constitutes its own treatment algorithm, its own subtype that has to be recognized upon diagnosis of treatment, similar like we do with other oncogenes, and the individual treatment opportunities here for ERBB2 targeting. So now at this point, handing it off to Dr. Yang for the introduction of HER2 as a diagnostic biomarker.
Thank you so much for the introduction. I'm really excited today to discuss how HER2 is an oncogenic and actionable biomarker in non-small cell lung cancer, and also to explore some of the current recommendations on HER2 biomarker testing. So in this session, we're going to be discussing the underlying biology of HER2 as an oncogenic driver in lung cancer, review some of the recommendations on HER2 testing for patients with advanced non-small cell lung cancer. We're also going to go over some of the assays that we use in the lab for detecting HER2 biomarkers, and come up with different clinical strategies for implementing HER2 testing. So first, I just wanted to review the sort of remarkable evolution of biomarkers in non-small cell lung cancer, right? So first, we started in 1987 with the discovery of KRAS and then added EGFR in 2004. And then now in 2024, in the molecular era, we understand that lung cancer is really driven by both common and rare genomic biomarkers, many of which can be targeted with specific therapies in the clinical setting. And so today we'll be focusing on one of these driver alterations, namely HER2 or ERBB2, as an oncogenic driver and an actionable biomarker in non-small cell lung cancer. So first, we're going to start with some of the basic biology of HER2 signaling. So HER2 is a receptor tyrosine kinase protein that is encoded by the ERBB2 gene in chromosome 17 and is a member of the HER or ERB family of receptors. Structurally, it has an extracellular domain on the surface, a transmembrane domain, and then a tyrosine kinase domain, which sort of acts as the main engine. And in normal cells, binding of the ligands to the HER family of receptor leads to dimerization with HER2. And this is what really triggers the activation of the tyrosine kinase domain and the downstream signaling pathways through RAS and PIK3CA for cell survival and proliferation. Now, in HER2-driven lung cancers, you can have specific mutations, particularly in the tyrosine kinase domain, that would basically lead to overactivation of HER2 and the downstream signaling pathways, leading to tumor genesis. In addition, you could also have increased copies or amplification of ERBB2 gene that could lead to increased expression of HER2 receptors on the cell surface. And then having these high levels of HER2 then can increase the activity of the downstream signaling pathways, also leading to tumor genesis. And so based on these mechanisms, it's really clear that ERBB2 mutations, ERB amplification, and HER2 overexpression represents the unique oncogenic drivers in lung cancer. And all right, so starting off with activating ERBB2 mutations, we know that there are three main subtypes. The first and the most common is the exon 20 insertions, comprising up to 60% of all variants. And while these mutations can be quite heterogeneous, the Y772, A775 duplication mutation is actually the most common exon 20 insertion. And then next, we also have transmembrane domain mutations and extracellular domain mutations, most commonly the S310F. They comprise up to 10 to 20% of mutations each. And then in terms of frequency, these mutations can be found in up to 3% of lung adenocarcinomas, and these variants are typically associated with adenocarcinoma histology, never light smoking history, Asian heritage, and female sex, sort of similar to what we see in EGFR mutations. And then next, moving on to ERBB2 amplification as a driver in lung cancer. So de novo ERBB2 amp has been reported in up to 2 to 5% of non-small cell lung cancer, and notably very high levels of amplification as defined by copies greater than 6 has been seen in a smaller subset of around 1%. And in contrast to ERBB2 mutations, ERBB2 amp appears to be more associated with male sex and smoking exposure. So there's to be a different sort of clinical profile there. In addition to driving lung cancer in sort of the treatment-naive setting, as mentioned before, ERBB2 amp has also been reported as a bypass mechanism for acquired resistance to first-line osimertinib in EGFR-positive lung cancer. And studies have shown that ERBB2 amp can drive acquired resistance in 3 to 10% of patients who are progressing on targeted therapies, thus making this a really important biomarker not only for treatment-naive patients, but also with those with disease progression. Lastly, in terms of HER2 expression, this concept is analogous to HER2 expression that we see in breast and gastric cancer, where the different levels of HER2 expression are measured by the intensity of the membranous staining via immunohistochemistry or IHC. And then they're assessed microscopically by a pathologist like me using HER2 scores from 0, 1, 2, and 3+. And so studies have shown that HER2 overexpression, generally defined as 2 to 3+, represent a poor prognostic variable in lung cancer. And this can be seen in up to about 13 to 20% of patients. However, 3 plus overexpression is only seen in a smaller subset of around 2 to 6%. So in general, ERBB2-AMP is thought to drive HER2 overexpression, but I think studies have shown that the concordance between these two biomarkers is somewhat modest and highly variable. However, there is higher concordance and a tighter overlap between the high-level ERBB2-AMP and HER2 3+, which I think makes sense biologically, and there's really no correlation at all with ERBB2 mutations. So why are these HER2 biomarkers important for patients with lung cancer? Well, I think these biomarkers now represent actionable targets for patients with metastatic non-small cell lung cancer, particularly for those with the non-squamous and not otherwise specified histology. And Antonio, our medical oncology expert, will discuss in great detail regarding the therapeutic and clinical data, but I just wanted to give you a brief sort of preview of the clinical rationale for why these biomarkers are so important to detect in our patients with lung cancer. So starting off with activating ERBB2 mutations, we have trastuzumab deruxtecan, or T-DXd, which is a HER2-directed antibody-drug conjugate that has been approved in the second-line setting in many parts of the world. And I think we also have a lot of ongoing clinical trials in the space for next-generation TKIs. And so based on really the T-DXd approval, ERBB2 mutation is a clinical grade biomarker that is recommended in the NCCN guidelines for routine testing. And then next we have ERBB2-AMP. There are no approved therapies for this biomarker currently, but we will talk about how this biomarker can actually be helpful for predicting HER2 3+ overexpression. And so this is an investigational and evolving biomarker that I think can be tested as part of a broad panel. And then lastly, we have HER2 3+ overexpression. So in the US, T-DXd was approved for patients with advanced HER2 3+ solid tumors who have received prior therapies with a tumor agnostic indication. And so this includes lung cancer as well. So based on this specific approval, this is an FDA recognized biomarker that I think should be tested for all patients. And then specific guidance around testing is currently in development. And so given the importance and the clinical necessity of HER2 biomarker testing, we're going to talk about how we can actually test these biomarkers and assess these biomarkers in the clinical lab. So the ERBB2 mutations can be detected via PCR or NGS-based assays using either tissue or plasma-based liquid biopsies. And then ERBB2-AMP can also be detected via FISH on tissue or NGS-based assays that are compatible with both tissue and liquid. And then lastly, HER2 3+ overexpression can only be assessed using IHC currently on tissue. And then now we're going to delve a little bit deeper into these assays, starting with those for the mutations. So ERBB2 mutations can be detected using a PCR-based hotspot assays using RT-PCR or digital PCR, and these are really for detecting known hotspot mutations, including single nucleotide variants and insertions. And so this technique is fairly rapid. It has low DNA requirement and it's very sensitive. However, it does not detect all the activating variants, and I can actually miss some rare exon 20 insertions given the targeted design of the assay. We can also use a fragment analysis sizing assay where it will basically show you gains or losses in the size of the gene product. And this is really for detecting ERBB2 exon 20 insertions. And it has similar performance characteristics as the PCR assays. Again, important caveat here is that it does not actually genotype or read the variants. It does not detect SNVs like S310F, but it can capture all exon 20 insertions. And then of course we have NGS, right, which can take more time, requires more infrastructure and DNA input, but this can genotype and sequence all ERBB2 mutations along with many other actionable genes in lung cancer. So now moving on to assays for detecting ERBB2 amplification, right? Traditionally we have been using FISH, and here we're assessing ERBB2 copies per cell, but also ERBB2 and CEP17 ratio per cell, again normalizing the ERBB2 copies per chromosome 17. And unlike for breast and gastric cancer, there's really no standardized criteria, but based on the different values, we can actually detect the lack of amplification, the presence of AMP, or polysomy. And FISH is great really for low purity samples, given the fact that you can have single cell resolution. It's also technically very robust and has relatively quick. However, it's only compatible with tissue. Now, we also use NGS for detecting ERBB2-AM, and the way we do that is actually through full depth copy number analysis, so that the number of reads mapping to ERBB2 actually correlates to the ERBB2 gene copies that are present in the cell. So again, no standardized criteria. However, in general, ERBB2 copies of greater than or equal to 4 to 6 in diploid cells may represent amplification. And the big benefit of NGS is, again, the ability to detect the focality of the amplification, the genome-wide ploidy status, not just polysomia of chromosome 17, but the entire genome. And of course, we can assess for other biomarkers using tissue and liquid. However, as we talked about before, NGS does require more time, resources, DNA input, and importantly, you really need a high tumor purity, at least 20% of tumor content for accurate detection of ERBB2 amplification. And then lastly, for HER2 overexpression, here we're using an IHC assay using the 4B5 clone. And in particular, the HER2 guideline for gastric cancers were used for the trial leading to the pan-cancer approval. So here, we should really be using this guideline for lung cancers as well. And so given that HER2 3+, right, is the actionable biomarker, it's basically distinguishing 3+ versus not 3+. And again, this is an IHC. We need the tissue, and the specific guidance on how to implement testing is currently under progress. And then here's a specific guideline for HER2 3+ in using the gastric cancer guidelines. And you can see that there's actually two different templates for surgical samples versus biopsy samples. So for surgical resection specimens, you want there to be strong membranous staining in greater than or equal to 10% of cancer cells. Whereas in the biopsy specimen, you want there to be a cancer cell cluster composed of at least 5 tumor cells with strong membranous staining. So now we talked about the different assays. The next question is really, how do we integrate these different assays and create a testing workflow and strategies for comprehensive assessment of mutations, amplification, and 3+ overexpression in a real-world clinical setting? And so here I've come up with sort of the 3 most common clinical scenarios that I encounter in my clinical practice and show how we can craft a clinical strategy for basically HER2 testing. So, starting off here, we have de novo treatment-naive advanced non-small cell lung cancer. And so for these patients, I think it's really important to do NGS for mutations as well as for amplification. And if amplification is detected, and then IHC is unknown, I think we can think about sending the tissue for IHC to confirm that it's 3+ positive. Now, if there's borderline AMP, I think it's also reasonable to use FISH to investigate further because it works better with low content tissues, and IHC in cases that are amplified. And right now, there's really no clear consensus on the value of upfront HER2 IHC testing versus testing at progression, mainly because this is a relatively novel biomarker, the 3+ IHC in lung cancer, and the 3+ staining doesn't really impact first-line therapies. But I think many centers have or are moving towards this direction of routine upfront IHC, and I think this can certainly be considered. The second clinical scenario is a patient with advanced non-small cell lung cancer who is progressing on therapy. So many times these patients have already been sequenced using NGS for first-line treatment. So ERBB2 mutation status is already known, but HER2 IHC status is generally not known. And so in these patients, you should be really testing for HER2 IHC, right? And then sometimes we get patients where all HER2 biomarkers are unknown in this setting. And I think here, we could use a combination of IHC and NGS. PCR can be considered. However, if it's negative, it might be prudent to confirm this on NGS, given that, again, PCR is only a hotspot assay. It doesn't cover everything. And then the last clinical scenario is the painful but all too common situation where there is scant diagnostic tissue that is insufficient for NGS, and we need to assess for all HER2 biomarkers. So here I would actually prioritize IHC and then also perform PCR in that order. And if PCR is negative or insufficient, I think liquid biopsy may be considered. So to talk a little bit more about liquid biopsy testing for HER2, we know that liquid biopsy using ctDNA or circulating tumor DNA can be really helpful for cases with insufficient tissue biopsies or in situations where tissue is not readily accessible or available. However, it's also really important to talk about their limitations, mainly that its sensitivity is really dependent on disease load, stage, ctDNA shedding, so that a negative result should really be confirmed on a tissue sample. And then, of course, we can't assess HER2 expression via IHC using liquid biopsies, right? So for plasma samples, we can use an NGS-based assay to detect mutations in AMP, but if there are no alterations, if it's a negative result, or if HER2-IC score is not known, then we need to get a tissue biopsy for confirmation and assessment. And so here I just wanted to quickly emphasize again that really the issue for HER2 biomarker testing is really critical from the tissue perspective. From the moment of the initial sample collection via biopsy and cytology, we should be utilizing rapid on-site evaluation or ROEs to ensure adequacy of the sample for biomarker testing. And then the samples must be prepared appropriately using formalin-fixed preparations, particularly for HER2-IC, and other fixatives such as alcohol can also be used for cytology samples for molecular testing, but HER2-IHC should be avoided in alcohol-fixed samples. And then it's also critical to conserve tissue for biomarker testing by minimizing diagnostic IHC stains in the workup and saving the best block for biomarker testing. And then lastly, we need to order the appropriate assays that we talked about, ideally in a pathology-initiated reflex testing protocol. And the assays should be validated appropriately, have sensitivity down to 20% tumor purity, and the results should come back reasonably within 10 days. And so to quickly summarize, we discussed that activating HER2 alterations are oncogenic drivers and now actionable targets in non-small cell lung cancer. And so these are, again, ERBB2 mutations, ERBB2 amplification, and HER2 3+ overexpression. And so these can be detected using a wide variety of clinical assays, including PCR, NGS, FISH, and IHC. And in particular, the mutation and the overexpression are clinical grade biomarkers that are FDA recognized and actually should be routinely assessed given the approval of ADCs for these patients. And then lastly, we talked about how tissue management and test selection are really key and critical for optimizing comprehensive and accurate assessment of all types of actionable HER2 biomarkers for patients with advanced non-small cell lung cancer.
So it's my pleasure now to discuss the innovation of small cell lung cancer, focusing on the latest development in HER2-directed treatment strategy. At the present time, I think it's very, very interesting to discuss, to deeply go through all the data that until today were published, and then before to focus on the new development, I think it's very interesting to look back. And we have a lot of TKI selected, non-selected that were discussed and then developed in the phase 2 trials, focusing on, for example, afatinib, neratinib, or more recently with the perotinib, positioning, mobocertinib. Globally, we can see here that, of course, there was a signal of efficacy, but globally, when we focus non-selected TKI, the rate of toxicity was very, very high, and globally, the median progression-free survival was around 6 or 5 months. And we can see a very, very interesting study that evaluates the combination trastuzumab, pertuzumab, and docetaxel in patients with HER2 mutant disease. So in this trial that is very, very interesting, we can see that the colleagues led by Professor Mazires achieve an overresponse rate of 29%, and globally the progression-free survival was 6.8 months, suggesting very, very interesting efficacy signals here. And we can see also on the right part of the slide that globally there was no high rate of toxicity for this combination using 3 different agents, trastuzumab, pertuzumab, and docetaxel. When we move forward, we can see that the story for HER2 mutant disease, of course, focus on the use of dedicated ADC, antibody-drug conjugate. The first story for ADC was defined by the use of TDN1. So TDN1 confirmed an efficacy in this particular setting, both in patients with a mutant and overexpressing disease, but globally the efficacy was not so strong, with a median progression-free survival across 5 months. And the use of the new ADC, particularly with focus on trastuzumab, was of course defined by a development of second-generation ADC, in particular with a different payload, here topoisomerase 1, with a different DOR, very, very high, with the 8 for trastuzumab, and particularly from my side with the different development of cleavable linkers. That is one of the most interesting part of the new ADC that increase the efficacy of this new class of agents. And when we focus, of course, for the evaluation of trastuzumab deruxtecan, we can see that the first-in-class trial here was a DESTINY-Lung1. The DESTINY-1 was a phase 2 evaluating the trastuzumab deruxtecan in two cohorts, patients with HER2 mutant disease and patients with HER2 positive, considered the overexpression disease. In this particular presentation, we'll focus on HER2 mutant disease, but also in patients with HER2 overexpression. Data are very, very interesting, published, and they are progressing the development also in phase 3 in first line. And for patients with the HER2 mutant disease, we can see the overall response rate in pretreated setting was 54.9. Very impressive considering the setting, the biology setting, also the story, and also the progression-free survival was 8.2 months. And I think also the overall survival was interesting, 70.8. Interesting, we can see on the left part of the slide that the efficacy was also independent from different TKI pretreated, also for patients with HER2 amplification. But when we try to understand deeply the data from DESTINY-Lung, we can see also that in very interesting data coming up from the safety analysis. This is why not only for the toxicity that are well known, like nausea, fatigue, alopecia, vomiting, very, very normal toxicity also for classing the chemotherapy, but in particular for those that are reported in the right part of the slides, the interstitial lung disease or pneumonitis, that are very interesting toxicity for this kind of patient exposed to the trastuzumab deruxtecan, also alpha ADC. For patients exposed to trastuzumab deruxtecan in this cohort, we can see that any grade of ILD was identified more or less in 25 rate of patients, and we can see that globally this kind of rate was grade 1 or grade 2, but also we can see that there are some patients, 4 patients with a grade 3. And investigators and the colleagues in development department defined to develop the DESTINY-Lung2 trial to investigate the efficacy of a new dose 5.4 milligrams per kilo versus the standard dose evaluated DESTINY-Lung1 of 6.4 milligrams per kilos, with the primary endpoint, the overall response rate by blind independent central review, and also the safety as a secondary point. And when we focus on the data reported in this DESTINY-Lung2, we can see that globally, the response between the two different doses, the mitigate dose 5.4 and the standard dose 6.4, was very, very similar. We have a 50% for 5.4 and 56 for 6.4, but globally, I think the most interesting data here arrive from the safety analysis, and we can see that with the same efficacy, we can have a very low rate of toxicity, in particular when we focus on ILD or pneumonitis. With the use of 5.4 milligrams per kilo, the all-grade ILD was 14% versus 32% for the higher dose. So these results are very, very interesting, consider the clinical perspective of the trastuzumab deruxtecan in patients with HER2 mutant disease. There was a very interesting analysis testing line to evaluate the efficacy on brain metastasis for this particular setting, considered the limited number of data also available before the advent of trastuzumab deruxtecan. And here we can see that there was an efficacy for this kind of patient. We can see that the intracranial overall response rate more or less was 50% for a small number of patients exposed to trastuzumab deruxtecan with a dose of 5.4. A similar rate, a little bit lower, was identified also for the trastuzumab deruxtecan with the high doses, so confirming that there is no big difference between the dose, and globally, the disease control rate on the brain intracranial disease control rate was very, very high. So over 70% was 6.4 and 92% of a patient exposed to 5.4 milligrams per kilo. So really interesting data that confirm today standard of care for patients in a pretreated setting for trastuzumab deruxtecan. And starting from this point, there is at the present time an ongoing trial in first-line setting, the DESTINY-Lung4, that is a randomized phase 3 study investigating trastuzumab deruxtecan versus the standard of care defined as a combination of platinum penetrexed and pembrolizumab. The primary endpoint in this trial will be the progression-free survival by blind-independent central review. As a secondary endpoint, we have the overall survival or other secondary efficacy endpoint, including the efficacy on the brain and, of course, safety and tolerability. I think that trastuzumab deruxtecan set the new landmark at present time for patients with HER2 mutant disease. And of course, there are a lot of options under development to evaluate the possible combination. In the multi-core Destiny Lung 3, that is a phase 1b dose escalation of a multiple combination, we can see that patients with HER2 mutant disease, also patients with HER2 overexpressing disease, are under evaluation for many combinations, with or without immune checkpoint inhibitors, with a different kind of potential combination with chemo, with the pemetrexed, with the carboplatin, with the cisplatin, with durvalumab. So I think these are very, very important studies to identify some potential signals to develop in the future clinical trials in this particular setting. To reassume the story, we can see that today trastuzumab deruxtecan as the dose of 5.4 milligram is approved, is indicated for the treatment of patients with HER2 mutant disease after first-line treatment with the chemo plus immune checkpoint inhibitors from in European countries by EMA, and they also approved by FDA in the same setting. And it's very, very interesting to also report that the trastuzumab deruxtecan is also indicated for unresectable disease with the HER2 positive overexpression disease. Very, very interesting. But and now the results of trial ongoing, ready to start to evaluate the use of trastuzumab deruxtecan on first line for patients with HER2 overexpression disease. But the story is evolving very, very fast, and at the present time there are many new compounds under development. And the second part of the presentation, it's my pleasure to focus on two very interesting drugs. The first drug that I will be discussing with you is the BA2927088. That is an oral reversible tyrosine kinase inhibitor able to target HER2 mutant disease, also HER2 insertion in this particular setting, also for EGFR pathway. And this drug is very selective for the inhibition of HER2 mutation. And this drug also received a FDA breakthrough designation therapy based on the data that we'll discuss later, and also a previous a preliminary approval by the China anti-regulation approval in this particular setting. This drug, the BA088, was evaluated preliminarily in the phase 1/2 defined the SOL-1 trial in patients with pretreated disease with a dose starting from 20 milligrams BID, with the primary endpoint to evaluate safety and tolerability. And also second endpoint, of course, on the efficacy over response rate, progression-free survival, DOR, and disease control rate. The preliminary data show a very interesting and impressive efficacy in this particular setting. We can see with an overall response rate of 70% with a disease control rate of 82%. This was the first-in-class data for this particular setting with a DOR not to reach at the time of the first analysis. And when we focus on the special cohort, we can see that globally toxicity was characterized by diarrhea, mainly grade 1 and 2, but also we have more or less 20% of patients with grade 3 in this particular setting. Other toxicity characteristic with a rash, vomiting, or pyronychia. That's a very common class toxicity for these particular agents. And we can see that a very small rate of patients had a reduction of dose in this particular setting. When we focus on the cohort T of patients with a pretreated disease, we can see that there is a confirmation for overall response rate, and the confirmation was a 72.1 with an impressive disease control rate of 83.7. So I think that this data also with an indirect comparison with the trastuzumab deruxtecan in patients with a pretreated disease are very impressive, also considering that here we are discussing an oral agent compared to IV drugs. And there are also other evaluations here in this slide. So we can see that globally, there is a very interesting progression-free survival of 7.5 months with a DOR of 8.7 months. But it's impressive to show you in the low box on the right that the patient characterized by this particular alteration, this VMA insertion, achieve an overall response rate of 90% with a median DOR of 9.7, progression-free survival of 10 months. This is also very interesting because we are identifying a target in a target with high efficacy for these particular agents. The evaluation of safety in update cohort, we can see that globally the data are very, very similar to the previous, with the toxicity characterized mainly by diarrhea in 86 rate of patient and with a grade 3 or more in 25 patients. The other toxicity were very, very similar to the previous discussion. In the present time, already started, there is a very intense phase 3 trial. So the BAY 2927-008 is ongoing in the phase 3 trial, the SOL2 trial, compare the oral drug versus the standard of care, as in the Destiny Lung 4. Here we have cis and carboplatin plus pemetrexed and pembrolizumab, with the primary endpoint also here the progression-free survival by blind independent centuria, with a secondary endpoint also overall survival, different progression-free survival by investigator, duration, and also patient-reported outcomes. In this trial, we can enroll patients only with HER2 mutant disease and not patients with HER2 overexpression disease. The second oral drug here is very interesting, is zoncertinib, that is the second oral EGFR and HER2 specific TKI EGFR sparing, and also this drug as the previously received a 50A breakthrough designation therapy, and the same from the China organizing committee. And zoncertinib was evaluated as a multi-cohort dose-finding phase 1 trial in the enrolled patient with a pretreated disease, but also treatment-naive disease. And I think this was very, very interesting when we focus on the response. On the right part of the slide, we can see that globally the response is across 70%, 74% in particular, with a disease control rate of 91%. And globally, the toxicity was very, very similar to the other TKI, with many toxicity with the diarrhea and rash, with a low rate of grade 3 or more. And based on this assessment in the phase 1, 2 doses were evaluated, the 120 milligrams and 240 milligrams that were selected for the second part of the development. And here you can see a very, very strong and big important development with a different cohort for patients with the naive HER2 disease or patient with also pretreated HER2 disease in this particular setting. And also here, and later we discuss later about the efficacy, we can see that the safety was characterized mainly by diarrhea and rash, that the two main and common safety alteration compared to the other TKI, and dose reduction was achieved in the 11 patients, and dose discontinuation only 3% of patients evaluated. But very interestingly, we can see here that the efficacy, we have a 72% for patient exposure to 120 milligrams and 78 to 240 milligrams. So very, very similar efficacy with the two doses, with a disease control rate around 95% and 100% for the dose of 240 milligrams. Here we can see that also, despite it's a very, very small rate of patient, but interesting, we have efficacy on the brain, evaluating the different kind of trial of cohort in this particular setting. And here we can see on the left part evaluated by RECIST, and on the right part evaluated by RANO. And we can see and we can confirm that now these kind of drugs show an efficacy on the brain very standard, very, very similar across the two doses. And also for zoncertinib, there is now an ongoing phase 3 trial with the dose of 120 milligrams orally compared to the standard of care, also here defined as a pemetrexed and pembrolizumab, with the primary point of progression-free survival and secondary point of response rate and overall survival. The future landscape of your opportunity, of course, is impressive at the present time. We have many different agents that are now in development in the early stage, also in later lines. But of course, the two most impressive and interesting drugs in later development are the dongertinib and the BA008 that are ongoing now in the phase 3 study. So to conclude my presentation, very full of multitude of data, interesting, confirming that HER2 is a target now. HER2 mutant disease is a very confirmed target for patients with non-small cell lung cancer, in particular in pretreated disease, where trastuzumab deruxtecan confirmed to be the new landmark, waiting to more new opportunity. For trastuzumab deruxtecan, that is the new cornerstone. There is only ILD as a potential critic factor to also to identify a opportunity for a great management in the clinical setting. And looking for future opportunity, of course, the two oral track, the BA008 and the dongertinib, have the new potential upcoming drug, considering the preliminary data already that both already receive an FDA breakthrough initiation therapy. Thank you very much for your attention.
Wonderful. Thank you, Antonio, for this wonderful overview. I'm looking forward to discussing some of those common clinical challenges that come with non-small cell lung cancer in general, but HER2-driven non-small cell lung cancer in particular. And I want to start off, Shani, maybe you can help us. When you consider the patient perspective, what do they know about molecular testing, tumor profiling? What's the willingness to undergo testing? Would love to hear your perspective.
Okay, thank you so much for inviting me, for giving the patients and the caregiver perspective, because I always say when such a disease is diagnosed, it's not only the patient, there's a primary caregiver, and lung cancer happens to the whole family. So how do patients perceive the importance of molecular profiling? So in this study that was published in 2020 by Davis et al., they did a survey where they wanted to check how important is it to you to learn about gene variants that may affect your chance of responding to particular cancer treatments. So they saw that 84% thought it is very important. And if we look at the factors that were associated with higher perceived importance of molecular profiling, we see that these factors include being a female, having children, being married, and having more recent cancer diagnosis. In just a recent study that I also participated in this, we performed another big survey that went worldwide, and we wanted to know again what is the awareness among them. So what we saw that high percentage understood the importance of biomarker results, but regarding knowledge, let's say half of them say they have somewhat knowledge about the biomarker testing. So we need to be better in educating patients and caregivers about these testing results.
So when you consider the risks of testing, there's obviously a lot of stress with the diagnosis that comes with it. Can you maybe elaborate a little bit on the patient perspective on the stressors?
Yeah, so definitely when you're diagnosed with such a disease, of course, there's a lot of psychological effects and with everything. But if we speak about additional testing, so the risks emotionally can be emotional distress and fear and anxiety. When we have the result and it's a complex genetic information, and it may be overwhelming for patients and caregivers. The test may not be successful if there's insufficient tissue. You send your tissue, you wait for the result, and then they say there's not enough tissue, we have to do another test. Again, waiting for these. In addition, NGS and testing is not accessed in every country, and especially also for patients who are not new patients but who have to go through that again. So there is a financial stress. And then when the results come, of course, there's fear from the results. In addition, if there are no treatment options or they are not clear, this can also affect our psychological emotions. Learning of results that have a matched treatment but no access to the treatment. So what do you do now? And in addition, discovery of genetic mutations that raise concerns about the familial cancer risk. This is also problematic.
If you look at the information, how do patients and their families get educated about this? How do you understand this? It's very complex. I mean, we've heard earlier about the details of testing. How do patients actually get into an understanding of this?
Yes, this is a good question. You can see another study that was performed by Luce, an umbrella organization for patient organizations in Europe, where they found that emotions affect the quality of life with patients and caregivers with lung cancer. And actually, in this report, caregivers suffer more than patients in most of these aspects, including sadness, anxiety, fear, anger. So if we look at ways to improve what we discussed in terms of patients and caregivers, and we need to improve the doctor-patient communications. So a message to the clinicians is that explain what the procedure is, explain the testing, explain the waiting times. So the patients and families, when they know more, the anxiety is less. Also thoroughly explain the result and options, and I think really be transparent so the families understand. Today you can Google everything, but you don't really understand what it is. So we know that the journey is very difficult and has a lot of psychological impact. But in this era of, we call it a decade of hope in lung cancer, personalized medicine achieves the optimal prognosis, and this is best accomplished also through decision making and understanding that the rationale for molecular testing is knowing the biology of the tumor and matching treatment. And we have to do this with all the impacts of fear, anxiety, etc. But this is the most important thing.
Very good. So any key logistical considerations, anything that we need to consider?
Yeah, so I mean, I think there's a lot of different logistical considerations for HER2 biomarker testing, and there's, as you can see, there's a lot of different steps that are involved. But for the sake of time, I'll just highlight a few key points. I think one thing that we really have to incorporate is rapid on-site evaluation to ensure that the biopsy sample or cytology sample, has adequate tumor cells for biomarker testing. The other thing that I really want to emphasize is the value of pathology-initiated reflex biomarker testing at the moment of diagnosis and tissue management. I think that can be really transformational. And then lastly, just having the report that is really easy to understand and timely. I think this is really critical for our clinical colleagues at the end of the spectrum where they're trying to finalize treatment plans for our patients.
Very good. I think we talked about the key challenges in biomarker testing to a certain extent, but maybe a few thoughts here.
Yeah, so again, some of the similar issues that I've raised before, I think one big thing about HER2 in particular is the fact that we've known about HER2 for a while, but I think more recently it's become actionable, especially now with the HER2 IHC3+ coming out. So I think there's definitely limited awareness on the complexity and the recency of the data. So I think we have to just continue to raise awareness for HER2 testing through education, advocacy, and outreach. And I think that's really the big highlight for this slide.
Very good. We talked about the optimization of the multidisciplinary teams, roles, obviously for inclusion of pathology. Anything else to add here? What else would you recommend for best practices?
Yeah, so I mean, as you can see from this figure here, this is truly an incredibly multidisciplinary process from all the stakeholders that are involved through every step of the process, right? I think it's really key that we create a framework for multidisciplinary coordination through different sorts of mechanisms, including tissue management protocols, tumor boards, quality assurance, and frequent communication. And then lastly, I'll just mention that outside of the immediate hospital-based setting, I think it's also important to involve and to collaborate with external groups such as biopharma, diagnostic companies, regulatory agencies, and especially patient advocacy groups to create a more holistic and integrated experience for our patients.
Very good. So, Antonio, there's a good question for you. How are you going to sequence therapies? How are you going to use immunotherapy in HER2 is a big question. Tell us, what would your practice look like, and what side effects are you considering when you prioritize?
If we consider the story of patient with a driver, generally with a no smoking history, the idea to use immunocheckpoint inhibitor is not so strong. But there are a lot of data in support of using immunocheckpoint inhibitors, especially with HER2 mutant disease. In particular, in the last World Conference on Lung Cancer, there was very interesting data from China colleagues that supported that the addiction is not the detriment, and there are patients that benefit from immuno. And this is the reason why in the the phase 3 trial with the trastuzumab, BI, and the zocertinib, the standard of care evaluating the control arm chemo plus IO. So I'm in favor of this combination, but of course, as you know, and we discussed a lot of time, it's an open field, and we have a lot of data and experience to improve our understanding here.
Any conclusions, key takeaways for best practices? HER2, what are you excited about?
Yeah, so I mean, I would just emphasize that, HER2 is definitely an oncogenic driver. It is now an actionable biomarker, and it's a little complicated because there's different mechanisms of HER2 activation and ERBB2 activation. So I think it's important to consider that in the clinical lab when we're trying to assess for these biomarkers. And I think multidisciplinary collaboration is really key here to make sure that all the patients are tested for all the actionable HER2 biomarkers.
I would like to follow up with a question. When you talk about NGS versus single gene testing, PCR, what's the discrepancy? What's your recommendation for diagnostic testing?
Yeah, so I mean, I always try to prefer NGS over PCR-based assays, particularly given the fact that it gives you the more complete information. You can assess for other biomarkers outside of HER2, and it will make more sense for using a broad panel rather than just single gene. But I would also add that there is some utility for single gene assays like PCR for HER2 in cases that have low tumor content or insufficient for NGS. I think that those are some of the situations where PCR can be considered and can actually be helpful.
Very good. Antonio, I want to hear from you. Prognosis of HER2, any additional thoughts? If you have a clinician that discovers a HER2 mutation in clinic today, what would you do? How would you proceed?
So HER2 mutant disease, HER2 positive disease is a very negative prognostic factor for patients with lung cancer. And I think that if you are able to identify patients with this characteristic, you need to prioritize this kind of patient, in my opinion, for clinical trial, because clinical trial at the present time are very, very high potential to have an improvement for this kind of patient. Alternative, the use of trastuzumab deruxtecan that now is the standard in second line should be prioritized. So please be careful in the evaluation of this kind of patient because the prognosis is not so good when you are using only chemotherapy.
And you talked about the immunotherapy role already. You don't think it's the most compatible biology?
No, I'm not in favor to use immunotherapy alone in this kind of patient. We can consider sometimes the combination of chemo plus IO, but not immunotherapy alone. If we have a patient already exposed to chemo plus or minus immunotherapy, this the patient or for trastuzumab or for clinical trial with the oral drug, the BEI, the zocertinib. There are many options for this kind of patient, but I'm not in favor of IO in monotherapy here.
Okay. Johnny, what are your thoughts and takeaways from today's meeting for HER2 positive disease?
Yeah, I think it's really important to understand that the testing is the first step and a very important step. So when families are diagnosed, they really want to rush. They want the treatment to be started, but we need to communicate with them so they understand that if we can wait, we'll wait to see the results. Although there may be psychological impact of fear and stress, etc., but this is really important. I really recommend to communicate with families. We know that the doctors have so much things on themselves that you don't have the time. We know that, but let's work together.
I think those are wonderful words to conclude today's session. I want to thank my fellow panelists for those great summaries of the very complex disease space. But I think one of the messages to take home today is there is quite a bit of hope on the horizon, new additional therapies. We have to identify those patients with the best diagnostic approaches and then match them to the most specific therapies to optimize outcome and provide hope. Again, from my end, I definitely want to thank you for your participation today. Again, our sincere thanks on behalf of the panel, and hope you have a good rest of your day.